so we're gonna get started right now with our People Helping People segment with Dr. Thompson, and we're gonna focus on cancer treatment this morning. All right. Good morning, Dr. Thompson.
Hi, morning. Nice to be back.
Nice to have you back as well. Great. So, where do we start?
All right. Let's start talking cancer treatment. The reason I really wanted to include a segment on treatment is that a lot of times I've seen people avoid doing conventional treatment, and I think a big part of the problem is just that they don't understand what's meant to happen, and they're a bit fearful of what they don't understand.
Right.
So if in today's session we could just run through just some of the basics of cancer treatment to help make it a little more familiar to the public.
Right.
Yeah. That would help people, I think, if they're ever in a situation to make better choices. Yeah.
I agree, because sometimes I'm really not interested in taking any tablets for any basic stuff, so far less, something as serious as this.
Yeah.
So where do we start? We often hear about chemotherapy, but I know there's radiation and also there's cancer surgery.
No. Okay, so if you sort of go back to the lecture or the discussion we had about what cancer is, if you think about a cancer, a tumor growing, right? So you have the initial tumor growing, and then you have the tendency of the tumor to spread into the surrounding tissues, right? Or to invade the surrounding tissues. And then you have the tendency of the tumor to spread to distant regions through the lymphatic channels or through the blood vessels. So when you start to think about treating a cancer, the ideal situation would be to cure the cancer, and that would mean, if you think about it, to get rid of every last cancer cell from the person's body.
Right.
Right. So the most direct way to start that task would be to remove the original tumor. Now, when you do a cancer surgery, you're accomplishing a number of things. One is you're taking out the bulk of the tumor burden in the patient. But the second thing you're trying to do is to achieve a margin of clear, normal surrounding tissue around the tumor. Now, the idea is that even though the surgeon is looking with his naked eye when you're on the operating table, he can't see small cells or the tiniest cell that has invaded into the surrounding tissue, what we call microinvasion. Right. It's just not visible to the naked eye.
Right.
So what he has to do is sort of, take a wide enough rim or margin around the primary tumor to try and get as much clearance as possible.
Right.
Yeah. After that, right, then you're looking at, he's accomplished a number of things. He's taken out the tumor. He may have well cleared any microinvasive disease around the original tumor. He would have alleviated some of the symptoms. So for instance, in bowel cancer, like we discussed last week, the symptoms that occur due to obstruction by the tumor can only be relieved by removing the tumor. Right? So the mainstay of cancer treatment historically has been surgery. What has changed over the years is the extent of the surgery and the approach to the surgery. Right? Nowadays we try to cut enough but not cut too much, if you sort of imagine.
I'm always imagining as you're talking, because I'm really trying to understand it as well, even for me and my family. So I know persons as well would be getting, just seeing what you're saying, because you're also very descriptive, which I really appreciate. So you continue.
Okay, great.
Yeah.
Right. So let's use breast cancer as an example.
Right.
Right. If we talked about just surgery for breast cancer, once upon a time we took off the breast, we took off the tissue under the breast, we even took off the first layer of muscle. Right. We took all the tissue from under the arm. What that would lead to, of course, in those days, was a person who would survive the surgery, but they would have very limited use of the arm.
Right.
And the defect that we would create on the chest wall would be huge. And you'd get a lot of complications from the surgery. So over the years, what's happened with breast surgery is that you take out less and less. Okay. Right? So you no longer go with the muscle underneath unless you have to. Right? And now you can even just go with the lump itself from the breast and a 1 centimeter rim of clear tissue. Yeah, and that would be adequate, sufficient. There's really been a lot of advances. If you take bowel cancer, for instance, once upon a time you went into a rectal tumor and you just tried to get it out. Nowadays what they do is they can actually give you other types of treatment before your surgery to make it possible to take out less bowel. So there's less people or fewer people who are going to end up with colostomy bags because we had to take out so much bowel that we couldn't rejoin. So the trend in surgery has been to do less extensive procedures, and the upside to it has been better recovery after surgery and more functionality for patients. So that's been a huge thing. So that's surgery for cancer.
Well, that's good news. That is good news. I would say. So even when you take out less, because you explained that because of the tissue, the diameters around it might be infected, so you take out sufficient to ensure that it doesn't spread, right?
Correct.
So because you're taking out less now, does that mean, well, you're now going to have to do chemotherapy, or how does that
okay, that's a really good question. How it works is that after the surgery, when you wake up in that operating theater or in the recovery room, you sort of wake up with a question mark over your head, right? I imagine all my patients coming out of surgery with a question mark over their head, and the question is this cancer going to recur or not? And thankfully, because we collect data on patients internationally, we can sort of predict who's at higher risk for the cancer coming back as opposed to who's at lower risk.
Right.
And what we find is that certain treatments can lower the chance of a cancer coming back.
Tell us about the treatments, and of course tell us who is at higher risk and who is at lower risk.
Okay, so let's go back to breast cancer as a good example. Right? Just based on the size of the tumor, right? Anything that gets over 2 centimeters across, we would start to say, well, okay, the risk has gone up. Even 1 centimeter and above 1 centimeter, we'd say the risk is going up. If the person has, when we take out the glands or the lymph nodes from under the arm, from the armpit, if those lymph nodes were involved, then we know that this person has a higher risk of a recurrence. Based on the depth of invasion, if for instance there was, when we look at the sample under the microscope, we see that the margins weren't clear. We tried to get a centimeter around, but we didn't get a full centimeter. There was cancer cells within a centimeter of the border of what we took out. Then we know, well, okay, this person is at risk for a local recurrence. Now, once we work out that there's enough to justify doing extra treatment, then we recommend. And when I say justify doing extra treatment, remember, all treatment has side effects. Everything we do has a side effect. Even if you boil your bush tea, it might have side effects.
Easy on my bush tea, Dr. Thompson. But I know there are side effects to so many different things, and it makes it hard for us to,
It is.
To take a tablet knowing, okay, if I take this tablet or I take this whatever it is, that this might happen and the possibility of this exists. It's like you're now creating a new problem.
Correct.
And you have to take a tablet for that new problem, which also might have a side effect.
And that is a reality of treatment. I think it's the hardest sales pitch, for want of a better word, because when you come out of theater and you recover from your surgery, once the scar is closed, you feel pretty good. You're feeling normal, and here I come telling you that you're at risk, this thing might come back, and I'm going to give you something that's going to make you feel sick. So you came into my office feeling great, and now I'm going to make you feel sick with side effects. But the idea is that in doing it now, I'm going to save you from a lot of pain later on.
Right.
And that's when I say justify, that's exactly what we mean.
I understand.
The benefit must outweigh the harm.
Right. But where there's life, there's hope. I must say that. So even in dealing with situations like these, we don't want to have, say, oh, I have to take this tablet or whatever. But where there is life, there is hope. So now just try to do better, live better, lift your spirits so high that nothing really matters. Yes, and that's why you tune into Hope on a Sunday morning. Yes, continue.
Great. So let's say we've spoken about surgery, and we said that there are treatments that we can do to lower the risk of a recurrence. So those treatment modalities, let's talk about radiation therapy first.
Sure.
Now, radiation is maybe the most difficult one to get your brain around or get your mind around because it's not obvious. Yeah. Radiation is a type of energy. So if you imagine light coming from a torchlight as a type of energy, it's very similar to that.
Right.
What we do in external beam radiation therapy is that we're shining or directing a beam of energy at the person, right? That is going to deliver energy to the tumor cells and damage their DNA, damage their genetic material. What happens is that normal cells have mechanisms to repair their genetic material,
Okay.
whereas cancer cells don't. So when we damage their DNA, when they try to replicate, they're gonna die. Now, again, we always come back to side effects.
Yeah, well, I was waiting on that one. Yeah.
So what happens is that, remember, it would be lovely if I could take the tumor out or take my target out, put it on the table and just crank up the machine. Then I'd
Right.
kill every last cancer cell for
Yes,
sure.
and that's it. No side effects.
The problem is that the target is often inside a person
Right.
and it's surrounded by normal tissue and organs that the person will need to
Use.
continue.
Yes.
Yeah. So that limits what we can do. So what we do to sort of get around it, one of the sort of tricky things to conceptualize in radiation therapy is that if you have a source of radiation, right, the energy that the beam transmit decreases as you go further from the source.
Okay.
So if you imagine me shining a light on my hand, let's say I'm shining it from the side of my thumb straight across, the beam is going to penetrate right through.
Okay.
But my thumb
Would
is going to get the highest dose.
Yes.
My pinky is going to get a smaller dose.
Yes, but it gets a percentage.
Correct. So let's say I want to treat my ring finger,
Yes.
right? If I just direct my beam from the side of my thumb, what's going to happen is that yes, I'll be able to treat my ring finger, but I'm going to burn my thumb off.
Yes.
So what I do to get around that is that I move my beam from different positions.
Right.
So all the beams are going to intersect at the ring finger, which is my target,
Right.
but I'm going to give smaller doses to the surrounding tissue because I'm varying where my beam or where my treatment field is.
Right.
And that's sort of the
Wow.
magic in radiation therapy. Kill the tumor but spare the normal tissue.
Yeah.
Yeah, and that's basically what happens. Now another interesting thing with radiation is that it's very focused. Yeah, I could literally, with some of the newer machines, I could probably do my eyebrows. They're that precise. Yeah.
Well, that is good.
That's great.
That's really good because that illustration you just gave me with your thumb, you had me thinking about let's say if you wanted to get something in your stomach or whatever,
Correct.
or I don't
It's
know.
difficult.
It will be difficult because now you have the other organs that are around there that are being affected.
Correct. So I mean, if you imagine it, for instance, if I try to radiate your breast after you took out a lump, well, just behind your breast is your lung.
Yeah.
Yeah. And if it's your left breast, just behind your left breast is your heart.
Yes.
Right? So we have to be really careful. Yeah. And we shoot from different angles to make sure that we don't give too much of a dose to normal tissues. If, for instance, we're treating a man's prostate, well, remember his prostate is scrunched up right under his bladder.
Yes.
Right? And right behind it is going to be his rectum.
Yes.
So you end up with a lot of normal, natural tissue in the treatment field.
Wow.
So to protect them, you can shield and you can change the angle of your beam. That's one way that radiation is done, what we call external beam radiation therapy.
Okay.
The other way you can give radiation uses the same principle, but what it's called is brachytherapy. Now in brachytherapy, what you do is you take a radioactive source and you put it into the target itself. Right? So it emits a small dose of radiation right to the surrounding tissue and does not penetrate to the normal tissue outside. So you're getting it right to the target by inserting the actual source of radiation into the target. So we use it a lot, for instance, with early stage prostate cancer, where you actually have these little seeds implanted into the man's prostate, and that acts as the source of radiation. So you can use it, for instance, with tumors of a smaller size in an earlier stage.
Earlier stage,
Yeah.
right. Well, that sounds good.
Yeah.
That sounds good. I would hope by 2020 that we find a cure, just a complete cure for, you know, all these diseases, because they project 2020 to be such a fantastic year.
Well, put it like this. I mean, in my lifetime, I remember when I was doing A levels, we were just being taught about what they call monoclonal antibodies, which they thought would be the magic bullet. Basically, you take a cell, let's say a cancer cell, and you look at what's on the surface, and you have an antibody formed against the surface markings on that cell. And then you take a drug and attach it to the antibody. So when you put it into the person, it goes directly where you want it to go.
Okay.
And kills the cancer cells. And that was very theoretical when I was 19 doing A levels.
Right.
And I've lived to see it in my career.
Excellent.
I've actually treated people with monoclonal antibodies
Wow.
in our public service right in Trinidad and Tobago.
Excellent.
So there's great progress. I can't promise you by 2020, but there is cause for optimism.
Let's hope. Let's hope. Yes.
Yeah.
So we spoke about radiation. We spoke about cancer surgery.
Right.
Now we're going to talk about
Chemotherapy,
chemotherapy, which is
The one maybe people fear the most.
yeah. So let's break this down. What is chemotherapy?
Okay. Let me borrow something from what people commonly say. People will commonly say, "Doctor, chemotherapy is poison." They're not wrong.
Seconded.
They're not wrong. It's an interesting story how chemo was discovered or invented. It was during the Second World War, and a ship that had been carrying mustard gas actually crashed in a port somewhere in Italy. And of course, all the mustard gas was released, and a lot of the people in the port town died. So when they did autopsies on these patients, one of the things they noticed was that their bone marrows were completely depleted of cells. And then somebody got the idea, well, if these mustard gas had this effect, maybe we can modify some of these molecules and use it to treat things like lymphoma, which arise from blood cells.
Right.
Yeah, or leukemias. And that's how the first generation of chemotherapy, called nitrogen mustards, was invented. Yeah.
Interesting.
Oddly enough, some chemotherapy is herbal, for want of a better word. And when I say herbal, I mean extracted from plants. One of the common drugs we use in breast cancer, called taxanes, is actually from a plant, and it was discovered because the National Institute of Health in the US, looking for a cure, undertook this massive project to look at all sorts of plants to see which ones would have active compounds that could be used or developed into drugs.
Right.
So in response to that, yes, chemotherapy is poison in a sense. The way most chemotherapy drugs work is that they interfere with cell multiplication. And of course, cells that multiply more rapidly tend to be most affected. So cancer cells multiply more rapidly than normal cells, so they're susceptible. But what you also find is a lot of your normal tissues have high rates of replication,
Right.
just as part of their function. So the tissue that grows my hair, for instance, the tissue that lines my gastrointestinal tract, the tissues in my bone marrow that constantly have to make blood cells, they're always undergoing replication. So when we give you chemotherapy, it's medication that we give that's going to work throughout your body. Yeah, either we give it as an infusion into your veins, or we give it as a tablet sometimes. But bottom line is, it goes throughout your body and will affect cells that are rapidly multiplying.
Okay.
So what you find when you do chemotherapy is that there's a sort of cycle of complication or side effect and recovery.
Right.
So what happens, one of the main side effects of chemo that we actually worry about, not hair loss, but actually lowering the person's blood count. When we give you chemotherapy, your white blood cells that fight off infection are going to become depleted. Your platelets that help you stop bleeding if you get cut, those numbers can fall as well. And then your red blood cells, where the hemoglobin is to carry oxygen around your body, that can also come down. What we find is, for instance, a given treatment regime, let's say I give you treatment today and we count today as day 1. For some of them, by day 10, your white cell count has reached its lowest point and you're actually susceptible to infections. And if you get an infection, it could actually kill you.
Right.
And then by about day 14, your count starts to come back up. And by day 21, you're back to normal. So what we do basically is we know this is going to happen, we anticipate it, and we take steps to protect you during days 10 to 14. Yeah, and those steps, there's an injection that we use that actually stimulates your bone marrow to make white blood cells to get those counts back up and have your natural immune system protect you. So in a nutshell, that's how chemotherapy works. Now, of course, we're very familiar with some of the other side effects like hair loss. The hair grows back. It's not permanent. It grows back sometimes with a different texture, sometimes with a different color, but you'll get your hair back. We're familiar, for instance, with chemotherapy causing nausea and vomiting. There's a lot of progress on that count because that was one of those things that was really intolerable. And there are a lot of modern drugs that we use to stop the nausea and vomiting. So for instance, some of my senior doctors at Radiotherapy Center in St. James would talk about when the chemotherapy ward used to have buckets. Yes, for people when they got upset.
Right.
I never saw that in my lifetime, or in my time working at St. James, because
right.
The drugs were just a lot better.
Right.
Yeah, so we've made a lot of progress in terms of managing the side effects of chemotherapy.
Okay. I like how we say managing the side effects of chemotherapy. What about for instance, when you're taking antibiotics, right? They say don't do certain things, drink a lot of water, do this, that, the other. What are some of the things that you tell persons whilst taking chemotherapy? Or do you have, for instance, chemotherapy is something that you have to be administered to someone, a patient at a clinic, or is it something that you can go home and you have to take it or whatever? I don't know.
Okay, so some of them are tablet form.
Right.
Right, and you take that and you go home and you take it for how many ever days it's prescribed, and then you stop and you come into the clinic just to be checked out from time to time.
Right.
The key thing really is counseling people. People who know what to expect aren't alarmed when it happens. So for instance, one of the platinum-based drugs, if I give it to you now and you handle something cold, right? About 48 hours after treatment, if you handle something cold, you'll feel like you're getting shocked.
Wow.
Electrocuted.
Right.
If you drank a cold drink, you'd feel like you're getting shocked in your mouth.
Right.
If you were in an air-conditioned room and you're breathing in cold air, right, you'd actually feel like you're losing sensation in your windpipe and that there's no air going in or out, which of course freaks people out. But once you counsel people about it, they know, well, for the next 48 hours, avoid these situations. And I must say the unit across here and the unit in St. James do a really good job at advising people or counseling people on their side effects. So they know what to expect and they know what to do in a situation. And they sort of take ownership of the patients and make sure everybody is doing okay. So there's a lot of things that for different drugs that you have to advise people differently.
I understand. Someone is asking, can chemo cause blindness? The person says they don't know someone who has had to stop using the treatment as it was affecting their sight.
It can. You can get visual disturbances. Yeah. You can get numbness in your extremities. You can. There's really quite a large range of side effects.
Right.
What happens is that the balancing act is always going to be between benefit and risk. Yeah. So what happens is when you're monitoring a person on treatment, you're trying to decide, should I keep going or should I stop? Yeah, have we gone beyond what this person can really tolerate?
Right.
And there's a lot of flexibility in terms of dosage adjustments and using different combinations of drugs to make things tolerable. A lot of times people sort of imagine that a person over a certain age cannot do chemotherapy, and that's just simply not true.
Okay.
That's a sort of age discrimination.
Well, I was thinking that as well.
Nope.
Yeah.
It doesn't hold true, actually. I've actually successfully treated here in Tobago people over 80, and they were pretty comfortable, and it all went well.
Wow.
But you adjust what you're doing. It's not a one size fits all.
Right.
Same dose for everybody, and
well, with a
best.
doctor like you, Dr. Thompson, and this is a plug for you, of course, you know, you're very detailed and you take pride in what you do. You pay attention to what you're doing based on what you're saying. You don't even have a paper in front of you, and it's like you know. So once you know what you're doing and you administer it well, you know, persons would live. I'm not saying that other doctors would not make them live, but I'm just saying that once a doctor is paying attention to what he's doing and it's not a hustle or you know, he's irritated or whatever it may be, I think that's key as well, how you administer to someone. Because I remember a lady talking to us one time, giving us her experience when she went to do the chemotherapy, but the nurses and the persons around her were so warm, so she just did not even pay attention to what was happening to her. So that in itself helps a patient or helps anybody that goes to the hospital when it is you have a warm, a hospitable service, you know, rather than
I'll be really honest with you. I was really privileged to get a chance to work in oncology.
Right.
Because it changed me as a doctor. It changed me as a doctor. It changed me as a person. It made me slow down. I used to be, not proud to say, but a hospital doctor through and through.
Right.
All lights and whistles and excitement, adrenaline, that kind of thing.
Right.
And when I got to St. James, it was like, oh God, this is boring. This is so slow. It was like going from hunting to going to gardening. And then I realized that gardening is slow, and it makes you pay attention, and it makes you focus, and it makes you understand that the person across the table is a person. And it was easily the best accident ever happened to me.
Excellent. That's a wonderful hope story.
It is actually.
Excellent. That is wonderful to hear. And sometimes that's what we need. We need something to wake us up, to show us that, hey, this thing is real, or this is happening. So I'm glad that you had that experience, so that you can now share, and be so willingly and passionate about what you do, to be with us here on People Helping People, on Hope, and to be part of the People Helping People program. We have 2 more minutes. I don't know if anybody would like to text in any more questions. 4893828 if you want to have these questions answered. Okay, yes, we do have. All right. So the person would like to know, they want a little bit more information on you, Dr. Thompson. They say you sound knowledgeable, and I agree. You do sound very knowledgeable. And that's why we have you here for the entire month of October, so we can talk and just get answers. So tell us a little bit about yourself, because this person probably tuned in late. But we did talk about Dr. Thompson in the early.
Yeah.
So tell him again.
Just for background,
yes.
I did not specialize in cancer treatment. A sort of disclaimer off the cuff. What happened is that after I graduated, I worked at Port of Spain General, and then there was an opening at Radiotherapy Center St. James.
Yes.
And I was honestly just planning to pass through. And I went there, and I spent maybe 4 years working there, and then I came across here when we were opening the oncology clinic across here. And I worked with the clinic across here for 3 years. So I spent about 7 years in and around cancer treatment. And that's sort of why these things are so familiar to me, because ultimately the person has to trust that you are doing what you're supposed to be doing. And they can't know that you're doing it or not doing it. So hopefully you can explain things well enough so that people can accept what you're urging them to do.
Yes.
Yeah, once we can, I think, encourage and support people, we can get them to do what may be the most difficult thing they may do in their life. And I'll tell you another thing, people are incredibly brave. People do this sort of thing all the time.
Right.
Once upon a time, people used to leave Tobago, go to Trinidad at St. James, where it was the only place you could get chemotherapy in the public service, and then get back to Tobago, go on standby to come back up in the airport or come back up on the boat. Nowadays, thankfully we have a unit across here, so people don't have to go through that stress anymore. But people used to do it, and they used to walk. It's literally an act of faith.
Yeah.
They used to cross the sea to reach out for help and reach out for care, and then come back home. Just to close off, it's great progress we've made as a country. A lot of times we look at the bad things, we look at the flaws in the system or the gaps and the deficiencies, but I've been around enough to see the great progress.
Excellent. And where there's life, there is hope.
Correct.
So that's how we wrap up our People Helping People segment. Next week, God's willing, we will talk about palliative care. And that's how we're going to wrap up the entire topic, right? And Dr. Thompson, God's willing, you would be here and get your questions together so we can have, anything that you missed or would like to find out, we could go it over for you. All right, because it's all about getting answers and resolving. Well, it's not as much as helping persons understand cancers, as Dr. Thompson said. Once you understand what it is, you would know how to deal with things better, and I totally agree with that with everything in life. So that's how we wrap up our People Helping People. Dr. Thompson, thank you so much.
You're welcome. Great to be here.
Lovely.